In this first series of clips, I'm going to show you some techniques for improving thoracic mobility. So the first one I just call book open and closed. They're going to be in the side lying position, and having the legs in this configuration, that just kind of helps lock out the lumbar spine. The key with this is have them rotate as far over as they can and then work on breathing. So a deep breath in and all the way out. And as they breathe out, try to get further into the motion. I usually do 3 breaths with each roll, and then I roll back. The progression of this is in the kneeling position. So you want to have the inside leg all the way up against the wall and have them sit nice and tall or kneel nice and tall. As they rotate over, it's important that you try to keep that other arm locked on the wall. And once they get all the way over and across, breathe in all the way, breathe out all the way. That's going to make the ribs move, which is going to improve that thoracic motion. And then after they breathe out, do 3 lift-offs before they rotate back. Just like the one leg on the ground, usually 3 to 5 repetitions is enough to kind of get things moving. This next one is a push pull, and you can do this sitting down, or if you're going to have them standing, they have to be in a split stance. That's going to lock out the pelvis and the lumbar spine to prevent the motion from coming there. So they're going to pull with one arm and push with the opposite arm. Now, you don't want this to be so heavy that they can't get full motion, but you want it to be heavy enough that they really have to engage those muscles to get that full motion. And this is more of a muscle energy technique than it is anything else, but this is a really good one for getting that full motion. And this whole series here, this is really good for any throwers or unilateral athletes. If they're having difficulty opening up toward that throwing side, or if they're having difficulty getting a separation of the thoracic spine from the lumbar spine or the lumbar spine from the pelvis, this is a great series for them. So next, let's move on to the hip and lumbar spine. This is just a little mobilization I use. I'm stretching the hip flexor on the back leg, then I switch to the hamstring on the front leg. Just something I do as a warm up before I get into the next ones. And next, we have the pigeon stretch, and this is a great way of getting the glutes and some of those little hip external rotators to loosen up. A lot of tightness back here is going to prevent a lot of functional movement from occurring. If your athlete can't get into this position, they can always sit in a chair and cross the leg over and then lean forward. And now we're going to combine the hip stretching along with the thoracic and lumbar spine. And this is called the pretzel stretch. Not only does this stretch each individual segment, but now we're getting into myofascial chains. So if you look at my top leg, that's going to be stretching my glute, which then goes up to the QL on that left side, over to the latissimus on the right side. And that's going to also stretch on the bottom leg. I'm stretching my quadriceps, the hip flexor, which is going to go into the obliques on my left side, up into the pec on that left side as well. So it hits a lot of these myofascial chains. For this one, also a big focus on breathing. It's really hard to get into these positions. And so once you're there, breathe in all the way, breathe out all the way. And as you breathe out, try to get further into the position. And this is another one that's going to combine the hip lumbar mobility with also the thoracic spine. The key is to get that back leg into a really good hip flexor stretch and sink down into it to try to get a little bit of a glute stretch on the front leg. Um, Place that other hand down. You see my left hand is on the ground. And then you're going to try to rotate up and across. And when you're up there, try to imagine that you're smashed between through a pane of glass. About 3 to 5 seconds in that position. And then when you rotate back down, if you notice my right shoulder, I'm trying to drop that below the level of my knee and thigh as far as I can so I can reach across and over. So a big mobility stretch for this one. You can just see how stiff I am when I'm combining all these different elements together. Now we're going to move on to the upper extremity. And this whole series that I'm going to show you is I use this for my patients when they're starting to transition from passive range of motion Post surgically into the active assisted and active range of motion. What we're going to do is we're just going to manipulate gravity and the position we're laying in to help achieve full motion without getting a shrug sign. This first one is just scapular mobility. Trying to work the scapular clock as far away around as you can, trying to get the full motion out of it. I like doing both at the same time. That way it helps with the neurologic and movement retraining. So trying to get the biggest circumduction of that scapula around as you can. So we're going to move into getting shoulder flexion without getting a shrug. So first, we're going to have them lying in prone, and we're going to actually let gravity pull them into the shoulder flexion position. So they're not actually having to lift the arm, but the key here is engaging the scapula beforehand. A lot of people think of this as a prone row. Yeah, you're rowing to bring the arm up to that start position, but then you're just kind of keeping that engaged a little bit and allowing that arm to come forward. And that's huge for when we do transition them to the next positions, that they learn how to, cue that scapular, those scapular stabilizers before the arm moves. Next, we're going to move into supine. And the key with this here is you start with your hand on the stomach or the chest, and then they're going to engage the scapular depression, adduction, or those stabilizers. Then they externally rotate to neutral, and then they reach up. And again, we're reducing the weight of the arm because typically if we were to have them reach out in standing, the arm is the lightest when it's by their side and it's the heaviest at 90 degrees. But in this position, actually, the arm is the lightest at 90 degrees as they're approaching that end range of their allowed motion. So not only are we improving the mechanical advantage of the muscles here, we're also making them engage the scapular stabilizers and the external rotators prior to that reach. And it's a big movement retraining for them. Now I have the same exact exercise as what we just did, but now they're in side lying. And all that's going to do is it's going to just increase the amount of activity that they need in the scapular stabilizers and the external rotators. And, as they reach out to 90 degrees, the shoulder flexors don't really have to work aggressively because there's no gravity pulling them down. So this is just a great way to get more activity out of those glenohumeral stabilizer and that scapular stabilizer. This next one is short lever abduction and side lying, and it takes the same approach as that initial shoulder flexion in supine. And that's, as in standing, as you abduct the arm, it gets more challenging and more difficult to the shoulder as they bring it up into abduction. But in the side lying position, it's actually the most challenging initially. And then as they get toward 90 degrees, the amount of difficulty reduces tremendously. I also have them here in short lever. So instead of the arm being out straight, it's just bent to 90 degrees by my side, just to reduce the amount of activity that it's going to take to initially get it moving. So now I have not long lever abduction. It's more of a functional reaching into abduction. So same thing, side lying, depress, adduct the scapula, and then externally rotate, and then they're going to reach out and up. Now, whenever we test abduction with our patients or our athletes, we always have them, keep the arm locked straight. And same thing with flexion, but that's not how we functionally use it. So we can improve their functional return to normalizing their motion by turning everything into a reach, and that's exactly how we use it functionally. So I like to start with the elbow bent and then reach out into abduction, or in the next one you'll see me reaching out overhead into flexion from that flexed elbow, because that's functionally how we use it. So if we train them that way, it's going to help cement that movement pattern. But too many times, I see therapists and athletic trainers have them do long arms so the arm is completely straight as they lift it up into abduction or flexion. And that's not how we use the arm functionally. So try this pattern instead. So if you start with this series of active assisted and active range of motion for the shoulder, and then you transition them into the standing position, you're going to see a much easier time for that athlete or that patient and just doing it without getting a shrug. This next one is tibial internal and external rotation. Now, this one's big for, if you have somebody after ACL reconstruction and it's, approaching week, 10, 12, if they're still having difficulty getting their full extension or if their flexion is really slow, look at their tibial rotation. And a great way to do it is in this kneeling position because that allows them to fully mobilize that tibia. And always check the uninvolved side, see how far it can externally rotate, and then check the involved side. Same thing with internal rotation on both. Now remember, as that knee extends fully, that tibia has to externally rotate to get that screw home mechanism. And I've seen a handful of athletes that are just having a difficulty getting that full active external rotation because they're lacking that extension, because they don't have that active extension or external rotation. And the same thing with flexion. If they're having difficulty getting their flexion, they're getting kind of stuck around 130 degrees. They can't really get much further than that. Have them work on tibial internal rotation a little bit. If there's a deficit in it, have them work on it a little bit. See if that helps that out. Now, you're not wanting to go aggressive with this. You're not wanting them to, rotate it as hard as they can, but just restoring that motion here can help restore the motion in flexion and extension. Now, next is we're going to show a couple mobility drills. This is one of my clients, and I noticed one day that during her warm up, she was not getting a good depth on her squats, and she was really having to make up for her squat depth with her trunk flexion. So what I did is I had her then do a little test. You basically want about 4 inches between the toe or the end of your foot and a wall. And for some people like me, I have big hands, it's a fist. And for her, she had smaller hands, so it's a fist plus your thumb. And you put that space between the toe and the wall, and they should be able to get the knee to go forward and touch the wall from there. And on her right side, she was able to get it, but on her left side, she fell a little bit short. So initially, we're thinking, her Achilles is a little bit tight. So I went ahead and had her work on that. This is one of my favorite ankle mobilization techniques. You got to use a bench or something that's higher up because what you got to do is bring yourself down into that full position and then you grab underneath the bench and you're actually pulling yourself down into your leg. And that's basically giving you a good overpressure. Now, from there, they say find the corners. You got to kind of wind your tibia and your femur back and forth. You're trying to find the most points of restriction. And this is a low load, long duration stretch. So you're going to try to sit on this, a minute, 2 minutes. Everybody's a little different, but as long as they can tolerate this stretch. So she worked on that, and then this is retesting the motion. And you can see that worked. We got her that ankle motion all the way back. But next, when we look at her functional squat, you can see that, yes, she is getting a little bit deeper into it, but it's not what I want to see. She's not getting a full depth squat here. So what I'm having her do is hold on to a weight, and you actually want the weight to be the lightest one that you can use to allow them to sit full into a full deep squat, and then they're going to hold that position there. And what the weight's doing is it's offsetting their body. If I took that weight from her, she would fall backwards. I'm cueing her to stay nice and upright with her chest. And she's going to hold this. Again, if you can, try to do it for a minute or two. And again, the lightest weight you can use, because if you have too heavy of a weight, then that's going to do all the work for her. We're basically doing a a neuromuscular re education, putting her in the position, giving her something to assist her with it, and then kind of teaching her muscles how to hold that position. So now we're going to retest her and see how she looks. And you can see she is getting much deeper than the first time during that warm up. Now, you also notice she has a little bit of what we call butt wink as she gets all the way down. Now, I'm not going to have her exercising under a load into that, but you'll see when we move into the exercise next, I want to get her as full depth as I possibly can. So her exercise for that day, for this circuit, I was having her do a unilateral front squat. So that's a 35-pound weight there. I wanted her to get a full depth of the squat as she could, and you see that she's not going so deep that she's getting any of that pelvic tilting or the butt wink. Now I love using unilateral loaded squats because it gets a huge core and pelvic stabilization that you won't get with just if you did it in a goblet or with a back squat. So, if we had done this exercise prior to any of those mobilization drills, she would have compensated through her lumbar spine. Um, and she would have had bad form, and then we would either had to have reduced the weight so that we didn't sacrifice her back, or if we kept the weight high, she would have just, irritated herself. Now I'm demonstrating a myofascial technique, and I call this the ulnar drag. And this is great for the cervical spine. So you could certainly do this with an instrument assisted, and I do that also. But when you use your arm or the ulna, what you're getting is that skin on skin, and you don't use lotion with this because you actually want to have friction. You use your skin to kind of pull on theirs, which gives a really good stretch for them. Now, when you start this technique, you're going to have your arm pronated. And then as you pull down about halfway down the neck, you're actually going to supinate the arm as you go. So that ulna is acting as your instrument while you're getting that myofascial drag. You can also have them do some pin and stretch, like you notice me here. I stopped halfway at one point and I had her stretch further into it. Great technique. Next up is a manual upper trap and levator scapula stretch. And the key with this is they have to be completely relaxed. And what I do is I'll side bend the head away as I'm pushing down on the scapula. And you just want to take them to that first point of restriction. I also like doing a PNF stretch here. So after about 10 seconds of holding this, I'll give them a little cue. What I do is I kind of like shake my fingers or my hand on the scapula, and I also kind of like wiggle my fingers into their head. That way, that cues them where I want them to push. So they'll elevate the scapula and they'll also side bend the head against it, just a real light pressure. I have them hold it for about 5 to 10 seconds before I then try to take them further into the stretch. And I do that for both the upper trap and levator scapula. Next up, this is one of my go-tos for anybody who's having headaches, cervicogenic headaches, anybody who's having cervical range of motion deficits or loss or pain. What I'm doing is I'm having them lie supine and I'm taking my fingers and I'm going to palpate for C2. And I'm finding right at C2, so I'm kind of wiggling the head back and forth a little bit. And then I'm going to rotate the head to one side. And as I do that, I'm trying to do it. I don't want them to do it. I'm feeling for the moment that their C2 stops rotating on the segment up. So the moment that that segment stops, that's when I'm having them stop. Now, they certainly could rotate further, but they're going to get that motion with the lower segments. So I'm stopping them there. And then I'm having her rotate against it. Now, when she rotates back toward the left, my left hand, I'm pulling up on the transverse process, or really it's kind of like right on the facet. I'm keeping that pulled up, and I'm also pushing with my right hand into the spinous process. So I'm not letting that vertebrae rotate. So she's basically rotating everything above it opposite. And so this is a form of muscle energy technique if you do it that way. Most of the time, it only takes a couple of rotations to get it to loosen up, like she loosened up on the very first one. So then I take her back to neutral and I test it again. So I'm rotating over. As I'm rotating, my left hand is pulling that the transverse process up as my right hand is pushing the spinous process down. And I'm just feeling for that moment that the separation between it and the above segment stops going. And then I just drop down to the next segment. The further down you go, the further you have to get them to rotate to get their motion to stop, and then the further that they have to rotate against you to get that specific segment to open up and stretch. Now, you may also get some little cavitations here. By no means are you doing a high velocity thrust on it, so you're not even technically doing like a PA glide or anything. You're just holding it in place as they rotate. But you may get some little cavitations, and what they're going to feel is that it's a stretch. They're going to get like a deep stretch and pressure deep in that cervical spine. Now I'm doing the pretty much the same exact treatment, but this is a way they can do it at home. You'll see this done a lot of times with a towel. I prefer a heavy band. Now, if you have like the really thick TheraBand or the wide one, you have to fold it over, but this is just a CLX. Now, the key with this, the reason why it works is because it's going to grip and grab the skin. So as I rotate over, I'm going to that point where I can no longer rotate any further, or my pain, my stiffness, and then I'm pushing with that hand, and that's going to grip and help rotate the vertebrae a little bit further. So that's kind of providing a self mobilization. So this first time you see me doing it, and then after it loosens up, you can even add in that rotation against. So after I get all the way over there, I'm going to hold that arm and that band steady, and then just gently rotate my head back against it. Now you can't go too far. It's not as effective as when you do this manually because they're sitting up. All their musculature to support the cervical spine is turned on. So it's not as effective, but it's still a really good way of restoring that motion.